Well, good morning, and thank you for coming. Today is an event that we are co-holding with our fellow statistical agency, the National Center for Health Statistics. I'm John Thompson, the director of the Census Bureau. And we're going to be, there's a little bit of a real strange feedback here. Is it good? So anyway, on September 16th, we are going to be releasing, we and our colleague agents are going to be releasing estimates of health insurance. And today, we're really pleased to talk to you about the methodology that we're using to collect these statistics and how we're going to be producing them and what the estimates will mean when you see them on September 16th. We have at the Census Bureau, we will be discussing the methodology in our current population survey, and the National Center for Health Statistics will be discussing the methodology they use in the National Health Interview Survey to collect and produce these estimates. As I said, we are just delighted to be here, and I will let Charlie Rothwell, the head of NCHS, present. Thank you, Charlie.
Good morning, all. It's good to be here, and it's good to see you all here. And again, as John said, my name is Charlie Rothwell, and I'm proud to be the director of the National Center for Health Statistics. And we're here today to discuss two premier federal surveys, the Current Population Survey, or CPS, run by the Census Bureau, and the National Health Interview Survey of the National Center for Health Statistics, and how these surveys can be used to monitor the changes in health insurance coverage in our nation. Monitoring health insurance is nothing new for the census or NCHS. We've been very carefully doing so for decades to effectively measure changes as the health insurance landscape has changed. And we have done this through a variety of surveys. These two surveys specifically that we'll be concentrating on today are very all-encompassing surveys which cover much more than just health insurance. So why now have this technical briefing on these two surveys and strictly on health insurance? As you know, there have been recent findings published by various private surveys on health insurance coverage changes in the first months of 2014. And in mid-September, as John mentioned, both these two major federal surveys will be releasing statistics on health insurance coverage, while the CPS report will be for the 2013 health insurance estimates before coverages under ACA went into effect. The NHIS, or National Health Interview Survey, will be producing the first federal survey statistics on health insurance coverage for the first few months of 2014, and thus they also, together, can be used to monitor, I believe, in more detail, the evolving impact of the Affordable Care Act on health insurance coverage. We hope through this briefing to help you better utilize the information you'll be receiving from these surveys, and so today we're here to discuss these surveys' strengths and how they can be used to monitor the changes in our health insurance coverage, as well as provide you with an overview of future reporting, because there's going to be future reporting from these surveys beyond just the releases in September. Now, both these surveys are very large, in-person surveys, which are representative of the non-institutional population of the U.S. and are really the gold standard in measuring health status and income in our nation. And by the way, have also been collecting health insurance for decades. The CPS, and specifically its annual social and economic supplement, the ASEC, is a survey administered by highly trained field staff of the census, and includes health insurance questions, and is conducted over 3 months every spring, and the statistics are released each fall as a part of the annual release on income, poverty, and health insurance in the prior calendar year. No other survey provides the same level of detail on income. Now, in September, Census will also be providing insurance coverage rates for the period of February through March to augment what will be published by the National Center for Health Statistics. Now, the National Health Interview Survey is the principal source of information on health of the civilian non-institutional population of the U.S. and provides current statistical information on the amount, the distribution, and the effects of illness and disability and health care in the United States, as well as health insurance coverage. And by the way, it's been doing so since 1959. Now, beginning in 2011 with the funding provided by the Public Health Prevention Fund of the Affordable Care Act, we were able to expand the content collected in the HIS and expand the survey sample size to allow for more detailed national monitoring of the impact of ACA, as well as provide state-level changes in health insurance coverage. Now, as you look at your agenda, you can see that the upcoming speakers will be providing much more detailed and specific information on these surveys, as well as what can be expected to be made available, not just in September, but throughout the next year, and I might add, the years to follow. It's my pleasure now to introduce both Jennifer Day of the Census Bureau and Stephen Blumberg of NCHS, who will provide you with the specifics on these two surveys as they relate to health insurance coverage. Jennifer, please lead off the CPS.
The Census Bureau collects lots of data about many topics. Today, our focus is on health insurance coverage. I will provide a primer on the 3 Census Bureau surveys that collect data on health insurance coverage. Then I will cover the history of improvements in the current population survey measurement of health insurance coverage and discuss our research and testing efforts to improve our survey questions, and end with explaining the changes that we have made recently to better measure health insurance coverage. The Census Bureau collects and produces estimates of health insurance from 3 surveys: the current population survey, the American Community Survey, and the Survey of Income and Program Participation. So why do we have 3 surveys to measure health insurance? Well, it depends on what you need to know, as each has its own unique strength. Let's take a closer look. The current population survey is a monthly survey focused on determining who is employed and unemployed, and has been used to calculate the official unemployment rate since the late 1940s. In February, March, and April, we have a special supplement to the current population survey called the Annual Social and Economic Supplement. This contains a slew of detailed questions on income sources and is the source of the official poverty rate. Along with these questions, we also ask about health insurance coverage. These questions ask about the previous calendar year, so the estimates for 2012, as shown here in the figure, were collected in the 2013 CPS. The purpose of collecting the health insurance information in the CPS is to obtain a measure of health insurance coverage to be used along with the previous calendar year income and poverty estimates, thus providing an assessment of non-cash benefits and its impact on economic well-being. The American Community Survey is one of the largest surveys in the world, with a sample size of 3.4 million households annually. It is collected continuously throughout the year. Because of this large sample size, the ACS can provide reliable health insurance estimates for the nation, state, and local levels of geography. In 2008, we added the health insurance question as shown here. This question provides a list of health insurance types plus a write-in for respondents to check yes or no if they have that kind of health insurance. People who do not check any yes boxes and do not provide a write-in are counted as uninsured. One of the advantages of this list in the ACS paper questionnaire is respondents can see all the answer possibilities at once. The Survey of Income and Program Participation is a longitudinal survey that interviews respondents multiple times over several years. The strength of the SIP is its measurement of transitions in a broader context of many events, for example, on and off programs, in and out of the labor force, and so on. Beginning this year, we completely redesigned the survey to reduce respondent burden and reduce costs. In this new SIPP, we visit households just once a year but ask respondents about events for each month during the previous year using the event history calendar to aid their memories. Every year, the Census Bureau produces health insurance estimates for both the CPS and the ACS. However, these two surveys produce their estimates differently. The CPS provides estimates of the population without health insurance for the entire previous calendar year. That means if they had insurance even for one day, they are not included in this uninsured count. This year, we asked about January through December of 2013, and will provide next month the estimates of how many people did not have health insurance for all of last year. The benefit of the CPS is the combination of detailed employment and detailed income with a time series that stretches back decades at the national level, which produces an excellent picture of economic well-being of our nation. Similar to the CPS, the American Community Survey produces annual estimates of the uninsured rate. However, they are based on the average of responses collected during the whole year, with respondents providing their health insurance coverage status at the time of their interview. We publish estimates in the fall of the following year, so this fall, next month, we will publish rates reflecting 2013. The strength of the ACS is its large sample size, and we can drill down to smaller geographies and provide health insurance estimates for most communities. The SIPP collects monthly estimates and can provide a full context of transitions for many topics, including health insurance. The focus today is on CPS. We began over 30 years ago asking about health insurance coverage on CPS for only part of the population when Congress directed the Census Bureau to collect data on non-cash benefits such as the government-provided health insurance to show its impact on poverty. The following year, at HHS's request, we added all types of private insurance to our collection. A few years later, in 1988, we redesigned and expanded the questions to collect prior year insurance status of all household members. This is the first population estimate of health insurance in the CPS and reflected health insurance coverage status for the calendar year 1987. Since then, we have released estimates of health insurance coverage in the fall of the collection year with the official poverty report. During the 1990s, researchers could see that the CPS estimates of uninsured seem higher than those of other major surveys, indicating that underreporting might be a larger problem for the CPS. In response, we added a verification question at the end of the supplement. This asked respondents who had not reported any health insurance coverage whether they were, in fact, uninsured during the previous year. This resulted in an 8% decline in the uninsured rate, as shown here in the slide in the circle, with the two estimates for 1999, thus moving the CPS closer to other published estimates. For the 2000 estimates, we added a new question about the State Children's Health Insurance Program, SHIPP. And in order to provide new, reliable state-level estimates of health insurance coverage, we added 28,000 more households to the sample to enable us to measure the effects of the new program. In 2011, we enhanced our data processing methods and released revised estimates on health insurance coverage back to 1999. In addition to question changes, sample changes, processing changes that directly affect health insurance estimates, we are continuously improving our survey collections to provide the most accurate and up-to-date information for all estimates. Footnoted here are several improvements to the survey and estimates, including changes from when we went from paper to computer-assisted interviewing, weighting improvements, and others. All of these are noted in our annual published reports. Even after adding the verification question and the CHIP question, research suggested that CPS needed further improvement, as the estimates still were not in line with other sources. We confirmed some of our concerns with the estimate differences between the CPS and other national surveys with the Medicaid Undercount projects. We also researched reporting problems in the survey itself, considering, for example, whether question order matters. We held focus groups, cognitive testing, and field tests. We conducted expert reviews, interview debriefings, record check studies, and other kinds of research, working to find any potential source of measurement error. Our goal was to make every reasonable effort to produce the best health insurance coverage estimates with the CPS. This research in the Medicaid Undercount project was conducted through a joint program with the Census Bureau, several agencies within HHS, including NCHS, and SHADAC, the University of Minnesota's State Health Access Data Assistance Center. It found the CPS undercounted Medicaid enrollees by at least one quarter compared to the Medicaid administrator record counts, even after adjusting for differences in the two data sources, how they counted enrollees. An undercount of Medicaid enrollment by CPS would tend to lower overall health insurance coverage estimates, and the existence of a Medicaid undercount suggested that the CPS health insurance questions needed improvement overall. Other research we did suggested that the CPS health insurance estimates had some reporting problems. The questions were retrospective about health insurance during the previous calendar year, that is January to December, and the health insurance coverage status can change over a course of a year. So questions about this long reference period may lead to response errors. For example, some people may report their insurance coverage status at the time of their interview rather than the coverage status the previous calendar year. Research also showed, in addition to the calendar year reference issue, that health insurance questions were designed to be read where each type of coverage is asked of everyone, regardless of prior answers or information. The CPS provides no visual clue as to the full array of choices as it is conducted with a field representative reading the questions out loud with one question after the other. Respondents may say yes to the first type of coverage that sounds close to what they had, which can lead to over-reporting of some types and under-reporting of others that appeared further down on the list. Respondents struggle with the meaning of the questions and get confused among plan types, especially public programs. Moreover, the health insurance questions on CPS are asked in a household-level design where household members may be forgotten if they are not mentioned by name. After a final round of cognitive testing in 2009, we ran a field test called the Survey of Health Insurance and Program Participation, or SHIPP. This tested a new approach to measuring health insurance. The aim was to capture coverage in a more intuitive way and make it easier for respondents to correctly identify their coverage. The questions were shorter and simpler. The first question was a simple yes or no to determine if the respondent currently had any coverage. The question then drilled down as needed and were designed to clarify areas of ambiguity and reroute respondents to the correct coverage path. The instrument used previous answers about age, income, and other coverage within the household to present appropriate follow-up questions that could capture unreported plans. And finally, the new question design used a hybrid flow of both household and person-level questions. It began by asking person one about his or her coverage and then fill in the information where appropriate for other household members, so the questions don't have to repeat for each person. We compared this new method with that asked currently on CPS and ACS, and this new format provided the basis for the proposed style of questions for the full-scale national content test in 2013. While all this research was going on, the Affordable Care Act health reform law passed in 2010. We realized at the time that several of its provisions would change how people answer their health insurance questions. People would have new ways to obtain health insurance, including through state insurance exchanges, now called the marketplace, and the number of people who would be eligible for subsidized health insurance premiums would increase. We started to consider how we were going to measure health insurance in this new climate. Two states already had health insurance exchange type programs, Utah and Massachusetts. The Utah program was focused primarily on businesses, and since the Affordable Care Act was modeled after the program in Massachusetts, we focused on research in Massachusetts. We had 3 phases of research, starting with expert consultation, focus groups with exchange participants, and finally cognitive interviews with people who were enrolled in the Massachusetts healthcare system and those who were not. In March 2013, we ran a national test that combined the lessons learned from the 2010 SHIPP test and the cognitive research in Massachusetts. It included a redesigned list of health insurance coverage types, new questions about the exchange marketplace participation, and additional questions on employer-offered health insurance. This was an operational test for both a new health insurance section and a revised income section. The test included all the same sections as the production CPS, something that SHIPP had not done. This would allow us to make sure that test questions worked in the context of the full array, a full survey, where the health insurance section appears after a full panel of questions on labor force and another one on income. We wanted to be sure the addition of the new health insurance items would not slow down the instrument, and we wanted to ensure that the flow within the health insurance section worked well. Moreover, the timing of the test provided an opportunity to provide the test questions, to compare the test questions with the production CPS. With a sample size in the test health insurance questions of 16,000 people, we could make statistically valid comparisons between the test estimates and the full production CPS estimates. Our goal was to see whether the test questions produced estimates that would be closer to the other national surveys, and whether the current coverage estimates of the uninsured were, as expected, higher than the prior January through December calendar year estimates. We found that the content test estimates of uninsured was lower by 1.4 percentage points than the production CPS, bringing it more in line with other national survey estimates. We also found that the current coverage uninsured rate exceeded the rate for the previous calendar year. Both findings confirmed our expectations. So we implemented this new set of questions for the production CPS this year. Our goal was to provide improved health insurance coverage estimates for calendar year 2013. This is prior to the major changes from the Affordable Care Act and thus provides a baseline year for accurately measuring future year changes. The redesigned health insurance coverage questions differ from the old questionnaire in 3 ways: the reference period, coverage types, and household level design. That is, the new questionnaire asks about current coverage question to improve the responses about health care coverage in the previous calendar year. It starts with general coverage questions and drills down to specific types of coverage via different paths depending on previous answers. And this approach is cognitively easier for respondents, which should result in more correct answers. And finally, we changed from a household level design to one that helps us capture health insurance coverage for all members of the household. We ask who else in the household had that plan type and ask about all household members by name to address gaps in household coverage. Further, the CPS includes new questions to measure marketplace participation as well as additional questions on employer-sponsored insurance offers and take-up, and we revised the questions on the medical out-of-pocket expenses. The general flow of the questionnaire begins with determining current coverage, then moves through sections on plan type, months of coverage, and additional household members covered by the plan, iterating through these questions, checking for gaps in additional plans. Once the instrument has determined the insurance status of a person for the entire previous calendar year and all the insurance types, it then moves on to the remaining questions in the health insurance section. Rather than going through the entire instrument mechanics now, I'll just highlight how the beginning works. As I mentioned, the new questions capture both current coverage as well as past year coverage. They begin by asking the respondent about his or her own coverage. This is most salient as the respondent is hopefully knowledgeable about his or her own coverage. And it's easier to remember coverage you have at the time of the interview. This acts as an anchor before asking about past coverage. If they have current coverage, they are then asked what type of coverage, and then if it started before or after the prior year, such as January 1, 2013. With follow-up questions to determine the months of coverage. If they don't have any coverage at the time of the interview, they are asked if they had any coverage in the previous calendar year. Then we ask who else is covered by the plan, at what months they were covered, whether they had the same months as the other people in the household or different months. We also ask if anyone outside the household is covered by their plan, such as a child living with another parent. This is a simplified illustration of the complex and detailed survey instrument we have implemented to measure a very complex and changing health insurance environment. In summary, the CPS provides more than 3 decades of health insurance measurement. Multiple surveys offer health insurance coverage measures with different uses, such as analysis by economic well-being, by geography, by transitions. Federal statistical agencies work continuously to improve data collection, to improve our understanding of these data, and to improve the reliability of our estimates. Changing a survey takes years of research and testing. We are very cautious about making changes. These CPS improvements will better measure health insurance coverage for the previous calendar year, thus providing a strong 2013 baseline to measure future changes in health insurance coverage due to the Affordable Care Act. And here's my contact information. And now we'll hear from Dr. Stephen Blumberg from the National Center for Health Statistics.
Well, good morning. And now we turn to the National Health Interview Survey. To reiterate a little bit about what Charlie Rothwell said when he initially described the NHIS, the National Health Interview Survey is the principal source of information on the health of the U.S. population. It provides estimates for monitoring progress toward public health goals and for addressing specific issues of current public health concern, including, of course, the health insurance coverage of the U.S. population and its relationship with health status and healthcare access and use. Like the CPS, the NHIS is a household survey of the civilian, non-institutionalized population conducted by interviewers from the U.S. Census Bureau. The NHIS, however, is a cross-sectional survey, which means that we generally interview each family only once. Interviewing is continuous throughout the year, with the goal of completing interviews in at least 35,000 households annually, and often more if funding permits. Now, the basic structure of the NHIS consists of three components: a core family questionnaire, and then questionnaires for one randomly selected adult and one randomly selected child from each family. The family core questionnaire is where all of the questions about health insurance coverage are located. These questions are asked for all family members, and the respondent is a family member who is knowledgeable about the general health and health insurance coverage of all family members. The sample adult and sample child questionnaires, then, are used to collect the majority of information about health status, access, and utilization that can be linked with the health insurance coverage data. Now, the NHIS has been collecting data continuously since 1957. Questions about the health insurance coverage of family members have been included since 1959. Now, back then, of course, the coverage options were more limited than they are today. Remember, back then, Medicare and Medicaid had not yet come into existence as we know them. So the questions asked about insurance that pays the bills for hospital visits, house calls, and office visits. Yet even then, there was concern that health insurance was not well understood by some respondents. So yes answers were followed by questions about the name of the health insurance plan. There were two reasons that NHIS asked for plan names. First, the intent was to use the question to identify and exclude single service plans, such as those that covered only dental or vision care or workplace accidents. Second, the goal was to distinguish between persons covered by Blue Cross and Blue Shield plans and those not covered by Blue plans. The NHIS has continued to monitor health insurance coverage since 1959. The monitoring was periodic until 1968, then every 2 years until 1986, and annually since 1989. Now, of course, the coverage options have expanded over the years, from Medicare and Medicaid to HMOs, TRICARE, and other managed care plans, to the Children's Health Insurance Program, and most recently, the Affordable Care Act. But the basic approach of the NHIS, that is asking about coverage types and then asking about plan names in order to properly categorize coverage types or to correct the initial response, remained the same. The last time that the NHIS was redesigned was 1997. Since 1997, the health insurance section of the Family Core has begun with a general question about whether anyone in the family is covered by any kind of health insurance or some other kind of health care plan. If so, then we ask what kind of health insurance or health care coverage each family member has. On this slide, you can see the various coverage types in the right-hand column. At the bottom of that column is no coverage of any type, which helps to identify uninsured persons who live with family members who do have health insurance. For each type of coverage, the NHIS then asks a series of detailed questions about the coverage. These questions are asked on a person basis for public plans and on a plan basis for private plans. Examples include questions about how the plan was obtained, who pays for it, whether it's a high deductible health plan, and whether it has managed care features. And just as was done back in 1959, we collect the full name of all private and public plans, preferably from a health plan card or other communication from the health plan. Finally, for those without coverage, we confirm that they don't have coverage and then ask about how long it has been since they last had coverage and why they do not have health insurance coverage now. Now, as was the case more than 50 years ago, we still recognize today that health insurance is a complex topic. Some inconsistencies in survey response are expected. Therefore, before producing statistics on coverage, the NHIS looks at the responses to the entire battery of insurance questions. If follow-up questions clearly suggest that the original coverage type reported was incorrect, the follow-up questions are used to assign the coverage type. This evaluation generally leads to corrections for only a few % of respondents. Where it does, it is generally the plan name that leads to a reclassification from insured to uninsured or from one coverage type to another. We use automated string searches of the private plan names to identify and exclude single service plans from coverage. We then use manual coding of the plan names to correct the data on type of coverage. This coding is facilitated by a list of plan names that is developed, maintained, and updated annually by NCHS. This slide lists the many sources of information that are consulted to maintain this list, which today includes more than 4,000 plan names. Following the evaluation and coding process, persons are classified into one or more of 10 coverage types. The variable names and descriptions on this slide are drawn straight from the final data files. It is possible for the same person to be covered by both private and public plans. And you will see in most of our reports that if you add together the percentages of persons uninsured, privately insured, and publicly insured, the sum will slightly exceed 100%. Now, 2014 brought a new source of coverage, the private plans that were obtained through the health insurance marketplace or state-based exchanges. Yet among our potential respondents, we expected that there would be much confusion about whether exchange-based coverage was private or public. At the end of last year and the beginning of this year, NCHS fielded an online survey that was called the Health Insurance Terminology Survey. It was fielded using an opt-in online panel, and I'm not suggesting that any specific estimates from this survey are a precise reflection of any specific population. But the survey made it clear that plenty of people were confused. So we asked whether it was true or false that the Affordable Care Act creates a new government-run insurance plan. The correct answer is false. The ACA does not create a new government-run insurance plan, but only about a third of respondents gave us that answer. Another third incorrectly thought that the ACA does create a new government-run plan, and a third were not sure of the correct answer. If some people think that their exchange coverage is a government-run insurance plan, then we expected that on our survey, they would misclassify themselves as having public coverage. Therefore, we recognized that new questions to capture exchange-based coverage would have to be asked not only for persons with non-employment-based private coverage, but also for persons who were said to have coverage through state-sponsored programs, other government programs, and other public sources. An interagency group, including HHS and Census Bureau staff, developed the new questions. The primary question that was added to the NHIS is at the top of this slide. Was the plan obtained through healthcare.gov or the health insurance marketplace? And in states where the exchange was given a specific name, that name was included in the question. Follow-up questions asked whether there was a premium paid by the family and whether the premium was based on income. Now, we recognized that these questions still would not be clear to everyone. In the health insurance terminology survey, 1 in 4 respondents had not heard of a health insurance marketplace. In fact, 1 in 3 could not pick the definition of the word premium from a list of possible definitions. So, just as the NHIS has always used the entire battery of insurance questions to categorize coverage types, the same was needed for categorizing exchange coverage. Now, we worked with the interagency group to develop a strategy for doing this, and the plan that we developed is based on one major guiding principle. We trust what the respondent tells us about whether or not their plan was obtained through the exchanges, unless there is clear evidence from other questions that the respondent's answer was in error. So, if a person is reported to have exchange-based coverage, that will be considered accurate unless the plan name provided identifies a company that we know does not offer exchange-based coverage. Or, if the plan name is unknown, the coverage is said to be state-sponsored or from another government program, but there is no premium. Similarly, if a person is reported to not have exchange-based coverage, that will be considered accurate, unless the plan name specifically identifies a known exchange plan name or exchange portal name. As you can see, the name of the plan is an important consideration when classifying people as having exchange-based coverage. Now, I realize that this is a bit complicated, so here's another way to look at the same method for determining exchange coverage. For all persons, regardless of the coverage type that they tell us that they have, if the specific plan name they gave us is an exchange plan, they will be assigned to exchange coverage. So, if they tell us that they've got Kaiser Permanente Bronze 60 HMO in California, or Blue Cross Blue Shield of Idaho's Silver Choice PPO, they will be assigned to exchange coverage regardless of what else they might say. Similarly, they will be assigned to exchange coverage if they said they had a directly purchased private plan or a state-sponsored or other government plan, and they provided an exchange portal name or they said they obtained the plan from the exchange and provided the name of a company known to offer exchange plans. But if the plan name is unknown or not collected, then we don't have as much information to drive decision-making. If the plan was directly purchased and was said to have been obtained from the health insurance marketplace, then it was assigned as such. But if the plan was said to be state-sponsored or from another government program, then there had to be a premium associated with the plan for it to be assigned as exchange coverage. Now, this decision was made out of an abundance of caution. Most Medicaid and other public plans do not have premiums, but most exchange-based plans do. Now, because we do not assign exchange coverage to public plans that do not have premiums and for which the plan name was unknown, we limit how often we might incorrectly reclassify public coverage to private coverage. In the NHIS, all individuals who are classified as having exchange-based coverage will be considered to have private health insurance coverage, regardless of whether they were reported to have obtained that coverage from a private or public source. So, as you can probably tell, this process for determining exchange coverage is complicated yet conservative. We've posted more details about this plan online in the special topics section of the NHIS website, and I encourage you to go take a look at it there. Well, my time's almost up. Let me close by highlighting a few strengths of the NHIS health insurance data. As Charlie Rothwell noted earlier, the NHIS data are collected in the context of extensive data on the health and health care of the individual. These coverage data reflect current coverage at the time of the survey, and because they've been collected using the same general approach since 1997, observed changes in coverage over time can be considered reliable. We collect extensive follow-up data, including plan names, to help us verify public and private coverage. And finally, as Jennifer Maddens will soon explain, we produce and release our national health insurance estimates on a quarterly basis, and we have sufficient sample sizes to permit annual coverage estimates for a majority of states. But before Jennifer does that, Tori Velkoff from the Census Bureau will talk about data release plans for the CPS.
Thank you, Stephen. Good morning. I'm going to give you a quick preview of what the Census Bureau plans to release from the 2014 CPS ASEC. This year, the CPS ASEC included some redesigned income questions as well as the redesigned health insurance questions. I'm going to review what will be coming out using the old and new questions and when. Before I talk about the releases, I need to explain a bit about the implementation of both the redesigned income questions and the redesigned health insurance questions in the CPS ASEC. After that, I'll talk about our upcoming releases. As Jennifer said, the Census Bureau did a lot of research and testing on the health insurance questions over the last several years. We were also testing some redesigned income questions around the same time period. In 2011, we did a cognitive test of these income questions. We tested both the redesigned income and the redesigned health insurance questions in the 2013 ASEC content test. After that test, we incorporated the new questions into the 2014 CPS ASEC, which has a reference year of 2013. How we implemented the new income questions and the new health insurance questions differed. For income, we used a split sample approach. In 2014, we had about 98,000 addresses in the full CPS ASEC sample. We asked the new income questions of about 30,000 of those addresses. The remaining 68,000 addresses received the standard income questions. We needed the split panel design for income because it preserves a time series and provides a bridge between the old and the new series. The CPS ASEC is the source of the official U.S. poverty estimate, so a consistent time series is a necessity. And the best way to make improvements and create a bridge is to take a split panel approach. The time series for health insurance is also important, but knowing there were other data sources out there on health insurance, specifically the American Community Survey, and knowing we needed a very solid baseline for 2013 with the new health insurance questions, we decided to ask the redesigned health insurance questions for the full sample. We needed to establish a baseline in 2013 with the new health insurance questions, and we wanted this baseline in place before the major effects of the Affordable Care Act took effect. And we can use this 2013 baseline for comparisons with future years. And only a full ASEC sample provides reliable estimates for small groups, some of which may be most affected by the Affordable Care Act. This slide gives you a visual of how this was implemented. Again, 68,000 addresses were selected to receive the standard income questions, and about 30,000 received the redesigned income question. The redesigned health insurance questions went out to the full sample of around 98,000 addresses. Again, the split panel for income and poverty preserves the time series and provides a bridge between the old and the new series. And the full ASEC sample for health insurance provides reliable estimates for small groups and establishes a 2013 baseline before the major provisions of the Affordable Care Act take effect. This fall, we'll be releasing two reports, an income and poverty report and a report on health insurance. These two reports, the source of which is the 2014 CPS ASEC, which refers to calendar year 2013. For the reports on income and poverty and health insurance that we're releasing in September, we chose to use the sample based on the 68,000 addresses. We did this for a couple of reasons. Income and health insurance are very closely related, so we wanted to have a consistent set of income questions for the health insurance report. And we're still evaluating the redesigned income questions. So we're taking a conservative approach and using the sample based on the 68,000 addresses for both reports. This sample is nationally representative of the total U.S. population. As I said, we're currently evaluating the new income questions. Note that health insurance and income are processed together, so when we have completed that evaluation, we will put out a public use file that will be based on the full sample. This file will be released in January of 2015. For next year, when we release the 2015 health insurance, we will plan to use the full sample as the baseline for the 2013 part of that report. When we release the health insurance report in the fall of 2015 for calendar year 2014, we will have the full sample for both the baseline, 2013, and 2014. The comparisons of these 2 years will enable us to show the impact of the Affordable Care Act. Next month, on September 16th, we'll be releasing two reports. Both reports will be based on the sample of approximately 68,000 households. For income and poverty, the report will be very similar to last year. We'll look at income and poverty by characteristics such as age, sex, race, and Hispanic origin. We will continue to present the time series for income and poverty in this report. For health insurance, we'll look mainly at 2013 data. As this is a new baseline year, there will not be comparisons to previous years of CPS. We will, however, look at health insurance coverage, coverage by type, and examine health insurance by age, race, and Hispanic origin, and other characteristics. We will use data from the American Community Survey to provide trends in health insurance coverage, and we will also use the ACS data to look at health insurance coverage at the state level. We also plan to have a webinar on the 16th when the reports and data are released. In that webinar, we will go over the results of the income and poverty report and the health insurance report. We will have subject matter experts in the webinar who can answer questions about the release. We also plan to release detailed tables on our website for income, poverty, and health insurance. We will release a public use microdata sample file that will be based on the sample of 68,000 addresses. This file will have the same variables as last year's public use file. As Jennifer mentioned, as part of the redesigned health insurance questions, we begin by asking if the person is currently covered by health insurance before we begin asking about coverage in the prior year. We will be releasing a measure of current coverage based on this question. These estimates of current coverage will be included with NCHS's release of data from the health interview survey. NCHS will release these estimates on September 16th. We are releasing these estimates with NCHS to provide a comparison to their first quarter health insurance coverage release. In addition to the items that we're releasing on September 16th, we have many related releases and events later this fall and next year. The week of September 8th, we'll be having our pre-release webinar for the ACS one-year estimates release. We will have people participating in that webinar to talk a bit about the new CPS questions. On September 18th, the one-year ACS estimates will be released. These data will be embargoed on September 16th. In mid-October, we will release the supplemental poverty measure, also based on the 68,000 sample, which is the same data used in the income and poverty report and the health insurance report. We will continue our evaluation of the redesigned income questions and plan to release some results from this evaluation in January of 2015. At the same time, January of 2015, we plan to release a research public use file, which will be based on the full sample. We will also continue to evaluate the redesigned health insurance questions and plan to release the results of this work in the summer of 2015. You can find more information on income and poverty at our website, census.gov. Income and poverty are very easy to get to from our homepage, as they have a topic page, and this is simply a screenshot of the income and poverty topic page. You can also find more information on health insurance on census.gov. Again, this is a screenshot of the topic page for health. Here's my contact information. Thank you very much. I'm now going to turn it over to Jennifer Madness from NCHS, and she will talk about their upcoming releases.
Thank you, Tori. Okay, so I'm going to give you a very brief overview of the planned NCHS releases of health insurance information from the Health Interview Survey. Now, as Stephen mentioned, the HIS is in the field continuously, with the final data for the year being released about 6 months after the end of data collection. So the 2013 data released at the end of last June. But in addition to being in the field continuously, the HIS is also based on random monthly samples. And this has given us the ability to analyze data for months or combinations of months. In 1997, the HIS changed from a paper and pencil interview to a computer-assisted personal interview. And the processing changes that accompanied that switch allowed us to take advantage of these monthly random samples, and we're actually able to release the estimates based on part of a year. And this was done through a new data dissemination program called the Early Release Program. The quarterly early release reports and the preliminary microdata files that are produced through this mechanisms are done prior to final processing and weighting. And so they are considered preliminary estimates, but they do allow us to provide very early access to our users on these key indicators, including health insurance. There are various components of the early release program. Every 3 months, the early release program produces 2 reports. One report has information on 15 key health indicators. Health insurance is one of these. The report was first released in early 2001 and had data from 1997 through June of 2000. Then there's a second separate report on health insurance coverage, which is much more detailed. That was first released in early 2002 and had information from 1997 through September 2001. Now, along with that release, we also have a set of web tables that are released at the same time, which include the quarterly estimates that are not in the report, and I'll say a little bit more about that later. And then actually throughout the year, we sometimes post some special tabulations on the web as well, but not quarterly. And also, along with the the early release reports, there's a preliminary microdata file that is released that contains the elements that are used to create that report. There are also some periodic reports on special health-related topics that are released throughout the year that are based on sub-year data. In the past, we've done reports on problems paying medical bills, sources of coverage, and healthcare access and utilization for young adults, and emergency department use for adults. We intend to update some or all of these reports over the next several years. And finally, there is a biannual report on wireless substitution for landline service. Now, other NCHS data products such as data briefs and National Health Statistics reports also provide information on health insurance and health care. Those tend to only be based on the full final year data, and those will come out at various times over the year. Now, all early release products are only web-based. We don't print any of them, but they're easy to find on the website. The easiest thing to do is to go to the Health Interview Survey website, and the link is here. Go down to the early release program where the arrow is pointed. It'll take you to the page for early release where it lists all the different products. Just link on the insurance one. That'll take you to a list of all of the insurance reports. Pick the one you want, and you'll get to the report. The format and the content of the report, we try to keep them pretty constant. We think that's easier for the users. They'll all kind of look like this. There's a highlight section, some introductory material, a lot of results, tables, and some graphs. So in terms of the release schedule, as we said, the quarter release comes out about 6 months after the end of data collection. So they come out in September, December, March, and June. After the first release in September, the reports become cumulative. So the December report has information from January through June. And the March report from January through September, and then the final report has the full year. However, if you want the specific quarterly estimate, so for example in December, if you want the January to March and the April to June estimates, those are what you can find on those web tables that accompany the report. So you can actually look at quarterly change on a quarterly basis over time. We do the cumulative reports because we get larger sample size, estimates become more reliable, and we can say more about change over time. Now, because the survey, again, is in the field all the time, it's in the field for that entire quarter, any estimate for that quarter is really some average over that time period. When things don't change much over time, that's nice. It kind of tells you something about the whole period. When things are changing, you really need to think of that estimate as kind of focused or centered on the midpoint. So for the September release, which is going from January to March, we think of it as being centered around mid-February. Again, the content is pretty standard across all of the health insurance reports. You get the percent and counts of persons who are uninsured at the time of the interview, who were uninsured at least part of the year, and who are uninsured for more than a year. And this is done by age group, and this is a time trend table in the report. However, not all years since 1997 are in every report. The tables were getting very, very big, so we started selecting certain years, but the old reports are on the web, and you can always go in and fill in the years that you might want. Also get the percent of persons who were uninsured at the time of the interview, the percent with public health coverage, the percent with private health coverage, by age and poverty status, again over time, and by race, ethnicity over time, and by age and sex, but that's just for the period of that release. So it's just for that quarter or for the cumulative quarter. And then the percent of adults uninsured at the time of the interview with public coverage or with private coverage, by education, by employment status, and by marital status, again, for the time period covered by that report. There's also information on the percent of persons in high deductible health plans, both without a health savings account and in a consumer-directed plan. And while the estimates are primarily for the whole nation, some subnational estimates are provided. Estimates are provided for 9 expanded regions, which are very similar to the census divisions, by state Medicaid expansion status, and by health marketplace type, so whether it's a state marketplace or the federal. And starting in December, we start releasing estimates for selected states, and the number of states that we have enough sample to release estimates on increases over the year. And of course, starting with the September 2014 report, we will give you the percent and count of persons under the age of 65 who have exchange-based coverage. And again, that's centered on the mid-February, and so does not cover the entire time of the enrollment period for the exchanges. The next release, which will come 3 months later, will cover that entire enrollment period. And again, as the year progresses, we'll be able to make estimates for population subgroups as sample size increases. You mentioned that the estimates out of the early release program are preliminary, primarily because they're based on a streamlined version of processing procedures. The procedures are quite automated. We don't do anywhere near as much of the manual evaluation as we do on the final report. And it's based on the prior year's list of health insurance plan names, those 4,000 names that Stephen mentioned. However, we did update the list with the latest exchange plans for the September release. The early release also does not distinguish between the individual types of public programs that comes with the final release. However, we continually monitor the differences between the preliminary estimates and the final estimates when the final report comes out, and they tend to be small. It's usually within 0.1 percentage points for the percent uninsured, and 0.1 or 0.3 percentage points for estimates of private and public coverage. And this is something that's monitoring that goes on every year. And the final product is the microdata file that's released along with the reports on a quarterly basis. In order to get these reports out quickly and the file out quickly, we have to do it before the files go through the very rigorous disclosure review processes that we have to do before we release any microdata to the public. And because of that, we can only release these files through our research data center. There are multiple ways to access these files. There is the data center in Hyattsville, there's one in Atlanta, but there are also the 12 Census Bureau data centers where you can get access to NCHS data. But there is also a remote access system where you actually don't even have to come to lovely downtown Hyattsville, but you can access the data from your own office. The website listed here will give you information about how to make proposals to get access to the data through the RDC. If you're interested in announcements about the early release program or any of the HIS data releases or any of the data collection activities, I encourage you to go to the website and get on the listserv. I think we're now going to take a very short break. Yes, maybe 5-10 minutes? Say 5-10 minutes? 15. Get back at 11:15, and then we will hear from our distinguished discussants, and then there'll be a question and answer period. So thank you very much for all of us.
How are you? Good. I'm just doing my logistics here because I was so,
We might put them all together.
like, it says next. Good. I was just trying to think. Now, with this setup, can I, it's just, my floaters are particularly bad today. Is it all right to stand over here?
Yeah, I think you could if you just switch.
But if I go in and out, it's going to screw up the recording, right? So maybe like that. That works. Late night with Mike O'Grady, right? Yeah. Good, how you been? Oh, no, I see 100.
I don't know. I mean, I don't know if you you probably won't know until you take out everything. Something must have came loose with it. It's not getting any juice.
Okay, I think we'll get started. It's my pleasure to introduce our two distinguished discussants, both of whom have a long history of expertise and work in this area. The first speaker will be Michael J. O'Grady, who is the principal of O'Grady Health Policy, LLC, which is a private health consulting firm. And he's also a senior fellow at NORC at the University of Chicago. Dr. O'Grady's work concentrates on health policy research and analysis for public and private organizations. His current research is concentrated on the interaction between scientific development and health economics, with a particular concentration on diabetes and obesity. He served as the chair of the National Academies of Sciences Institute of Medicine panel measuring medical care risk in conjunction with the new supplemental income poverty measure, and is currently a member of the National Academy of Sciences Policy Roundtable of the Behavioral and Social Sciences. From 2003 to 2005, he was the Assistant Secretary for Planning and Evaluation, ASPE, at HHS, where he directed both policy development and policy research across the full array of issues confronting the department. Prior to his role as Assistant Secretary, he served as the Senior Health Economist on the majority staff of the Joint Economic Committee of the U.S. Congress, and for several years, he was a Senior Health Advisor to the Chairman of the Senate Finance Committee, and held senior staff positions with the Medicare Payment Advisory Commission and the Congressional Research Service. Now, in order to kind of give us enough time for questions, I'm going to also introduce our second discussant, Gary Claxton. Gary is Vice President of Kaiser Family Foundation. He is also the Director of the Healthcare Marketplace Project and Co-Director of the Program for the Study of Health Reform in Private Insurance at the Foundation. Mr. Claxton, the Healthcare Marketplace Project provides information, research, and analysis about trends in the healthcare market and about policy proposals that relate to health insurance reform and a changing healthcare system. The Program for the Study of Health Reform and Private Insurance examines changes in the private insurance market under the Affordable Care Act as federal and state policymakers implement provisions of the health reform. Prior to joining the foundation, Mr. Claxton works as a senior researcher at the Institute for Healthcare Research and Policy at Georgetown University. From March 1997 until January 2001, he served as a Deputy Assistant Secretary of Health Policy at the Department of Health and Human Services. Previous positions include serving as a consultant for the Lewin Group, a special assistant to the Deputy Assistant Secretary for Health Policy at the Assistant Secretary for Planning and Evaluation, an insurance analyst for the National Association of Insurance Commissioners, and a health policy analyst for the American Association of Retired Persons. I thank both of them for joining us today, and I'll hand this over to Mike.
Thank you very much. I'd like to give you a little bit of the policy context here and a little bit of the history as well. It's important to know about kind of, those of us who get into the technical aspects of this, it's important. We want to get the most accurate numbers. We want to see these go forward. But it's also important to know that this is not the end in itself. This is the means to an end. That this data, this sort of information is used very heavily in very serious policymaking, and the accuracy of it is very important, beyond simply you want to do a good job and have an accurate survey. So I want to give you a little, as I say, a little political and policy history of what's going on. Back up 10 years ago in 2004, I was an assistant secretary in the Bush administration. We had successfully passed the Medicare drug benefit. It was on its way to being implemented, and the Bush administration was kind of turning, exploring kind of where did they want to move next. They were coming up on the election was going fairly well for them. They wanted to think about what, if they got a second term, would be one of their big pushes. And this question of reducing the number of uninsured was being pushed by then Secretary Tommy Thompson. So the approach was much more incremental, I would say, in terms of than what we saw later with the coming out of the ACA. We had in the Medicare drug benefit been given first the budget that we had to work with, $400 billion. And so we had to build, design kind of benefits and who was going to be covered and how you were going to do it, kind of working it into that. We couldn't go over $400 billion without really a hell of a good reason to go over it. And that was sort of our marching orders. So as we approached this one on the uninsured, what were the options you wanted to take to the president? What did you want to take to the secretary? How did you want to think about those sorts of things? We were thinking in a very incremental approach. Our political judgment at that point was that there wasn't enough consensus either on the amount of money or on who should get government coverage, that it would cover all the uninsured. whatever that number happened to be. But whatever that happened to be, we didn't see that it would be all there. And we wanted this more accurate estimates so we could slice and dice and think about different subpopulations who were the greatest in need. Not that if you had enough money, you wouldn't cover everybody, but you had people who were sort of at the front of the line, those most desperate in many ways. So this is basically the way we were sort of conceptualizing things in a policy context at that point. You were trying to identify kind of what your variables and what your key subpopulations. Now, you weren't really sure kind of how much money you would have and how far it would go into that matrix, but we were looking at it mostly in terms of time without insurance. We knew that there were some people who were just, I mean, the college kid who graduates and is uninsured for 3 months before he starts his first job, a concern, but not top of the list if you have limited money and limited time and limited political currency to get them covered. The chronically ill person who's been uninsured for months, if not years, that somebody probably moves up to the front of the line in terms of thinking about this. There were some people who weren't seeking insurance, as we kind of see now as well, can't afford, didn't necessarily, but it was a pricing thing, and there were people who desperate. Again, that kind of triaging, you're going to prioritize who you are, and then in terms of citizens, non-citizens here legally, and then illegal aliens were kind of third in line, if you want to think about that. So, meeting in the White House, this is 2004, exactly 10 years ago. You have a fellow at that point, the White House staffer was a fellow named Doug Badger, who has to start this is the Roosevelt room, it's got all this history to it, and his first slide comes up, and this is what it is. Mr. President, there are 4 surveys. The numbers range from 19 million to 45 million. The percentage of Americans uninsured, or people living in the United States uninsured, is roughly 7%, up to 15, 16%. Now, policymakers are used to dealing with uncertainty. This is not physics. They understand that. But this sort of a range of a doubling or more is really a heavy lift for most policymakers to kind of go with. If you told me that there were, it was 30 to 28, no problem. They can live with that. So that notion of what was going on, he went on further to explain that the media normally uses the $45 million number because it's a big number and they like it and they know CPS more than they know things like MEPS and some of these other surveys that are going on. And it's this situation, our ability to think about how we would slice and dice and kind of get down to these key subpopulations, that we would put priorities for some and, kind of second range for others, kind of shaky, pretty shaky. Now, as I sat there, it was clear in my mind, because I was kind of, what we call in the business the whisper dweeb, the guy who sits behind the secretary and kind of, whispers in his ear and slides in pieces of paper and whatnot. I'm thinking, I bet some poor devil sat here in 1993, 1994 and said, President Clinton, there are 4 surveys out there, and it goes, and the numbers were different, but the problem was still there. And so part of that idea of what the thinking was at that point was, this has got to change. We can't keep going this direction. There's got to at least be some move to think about how these things go forward. So, step 1, you heard mentioned before, I think Jennifer brought up the Medicaid undercount problem. So what we were also seeing simultaneously was states, for any of you who have ever worked in Medicaid data, the states for decades had the worst data that you can imagine. It was just horrible. Their administrative files, their claims, who was eligible, et cetera. They finally, by about 10 years ago, they were starting to get a little more modernized, better systems, and we started to see this pattern where the states were telling us, you would see a CPS number that said 2.3 million, I'm making that up, Medicaid in the state of California. And we get this call from Sacramento going, I don't think so. It's not, they had much different numbers. And it was pointing in the direction of undercount. And any of these things when you're trying to improve, you don't necessarily know going in. Is this an overcount, an undercount, what it's going to be? We also heard things, which I'm not going to talk tons about today, same kind of thing about employment-based health insurance. And not, again, was that being overcounted, undercounted? But it's all a question of getting to more rigorous data, more accurate data the best you can. So what happened was we did fund with ACF. ACF, for those of you who don't speak, HHS speak, is the Agency for Children and Families, basically the welfare side of HHS. And ASPE, which we funded a RAND to kind of go through the California data, go through the administrative records and find. And certainly we found that problem was there. We then took the next step and we funded 2 different teams. One of the problems in terms of government policy making and policy research is you really don't have a clinical trial. You know, you don't have a control and an experimental. One thing you can do to kind of proxy for that is you take 2 independent teams of researchers, you send them off, they know about each other, but you have a little bit of a firewall between them, and you see what they have. Much of policy debate, certainly in healthcare policy, often comes down to a methodological food fight between actuaries and health economists. If you remember the drug benefit, the ACA, anything going back there, the CMS actuaries, the Medicare actuaries kind of go, I think it's $500 billion. And the health economists at CBO go, I think it's $400 billion. And they, you know, they go over everything, but it comes out to that. So this was, my thinking at the time was I'd set up one team that was actuaries, one team that was health economists. Actuary Research Corporation is actually the consulting actuaries to CMS, to the Medicare actuaries, and the Urban Institute had kind of the top microsimulation model in terms of thinking about these sort of things. So they both went out to try and make estimates of what this undercount was. And as you can tell from my earlier comments, we were interested not only in the overall number, but could you identify key policy important subpopulations. The actuaries came up with an estimate of 9.1 million was the size of the undercount, 3.6 coming out of the economists out of the Urban Institute. We didn't take that as gospel or gold standard, but at least it felt like it gave us a range of what we thought we were dealing with. Non-citizens, they were pretty close, you can see, in terms of what was going on. Eligible for Medicaid. Another problem with this is where you know, was there a certain percentage of people who, if they went in and applied, would be eligible, could be signed up. So that was a different problem than offering them health insurance. They were already being offered health insurance, you just couldn't get them in the door. 300% of poverty, candidly in our discussions, we weren't thinking of subsidizing anyone really over 300% of poverty. So that was sort of another key population to sort of think about what was going on in this. Childless adults, that was sort of a key population at that point because the way Medicaid was being done, they didn't really cover childless adults. That got changed during the ACA. And then the remaining uninsured. So we were trying to get that feel, but they were saying that the estimates that had been 45 million were maybe 35, maybe 37, in that range. Now, we didn't stop there. I mean, because as you can tell from the earlier presenters, there's all these different things that go on. You want to make sure you've got it right. So part of it was just a convening. We brought the staffs of the 4 different surveys together. Candidly, that was something that I kind of hosted at ASPE, and I expected it to be quite a herding cats, sort of, I have to say, going into that first meeting, and I found that I was absolutely wrong. The staffs of the 4 surveys were kind of dying to talk to each other and compare notes and how do you do this, and the conversation was good. And so it was much more, I thought it would be kind of just protect my turf, and that's not what I found. Outside survey and health policy experts, we brought them in. There was a number of things that were kind of going on out there in the academic literature that candidly I was not convinced by, you know, and it kind of fell into the category of, well, Census probably didn't do the question right, and the people answering the, well, the American people kind of don't know how to answer questions. Well, it seemed a little dismissive to both the Census Bureau and to the American people, candidly. But you know, wanted to hear what they said, wanted to see what they had when they got a chance to talk to these staffs who said, well, maybe it's maybe, but maybe it's reweighting. Maybe it's kind of question wording. Maybe it's length of recall, some of these other things. And also brought in the main, and this is, you have to make, my focus at this point was what could be used in policymaking. So I brought in the main audiences for this. The actuaries at CMS, the tax people at Treasury, OMB, CBO, CRS. And again, how did they deal with this uncertainty? What were they doing? And what was going on, to sum up quickly, was these were very sophisticated users of this data, and they would pick and choose. So you would see, hopefully nobody from Treasury here, but you'd see a Treasury document, but you understood. They would sort of say if they needed to know something, as they do with filing and the way these things work, because there were a number of tax credit provisions for the uninsured at that point, they needed to look back. So they would use the MEPS because they got a 2-year panel. So they would take the percentage change off the MEPS and like apply it to a CPS number or apply it to an NHIS number. But they were sort of this, I mean, you know, as the methodologist, I'm sure you're going, but if the president is asking you to say, what happens if we did a 18-month look back and then decided, bump, you have, you know, you're expected to come up with a number. So consensus and cooperation, certainly, you know, the main thing that I found was that there was a lack of funding for much of this kind of methodological research to allow you to do that, and that was certainly something that ASPE could provide. So you heard mention of SHADAC before, the University of Minnesota folks that do this. They were doing that. They started out with one comparison of questions and methodologies across the 4 majors on the health insurance estimates. SNAC was a project, I think that stands for SHADAC, NCHS, ASPE, Census, and CMS. So just getting a little cute with the names there. But that was basically to go out and start to figure out, could you methodologically actually link survey individuals who took a survey with their administrative records? So you'd see how they answered the questions, but you'd say, no, the state of Maryland said they did have Medicaid for the last 18 months. And how are they doing that and getting to that? And there's at least 5 or 6 different kind of sets of that. And it's a great kind of resource now. It's getting a little old, but that idea of if you really wanted to see these linked files, it's a very powerful tool. Mathematica, Dr. Chaika here did a great one on income, again going across the 4. Now, one thing to keep in mind here, we were talking about uninsured, we were talking about questions of subsidies, we were talking about who was already really eligible for Medicaid. If you either had an overcount or undercount on your income, you were again going to be into not as much trouble as if you had an over or an under on health insurance, but you were not in a strong position policymaking. If you went forward with a provision that said, we think we're going to cover everybody through 300% of poverty with a sliding scale, and you've got that number wrong, and the incomes are really much higher, the bill ends up being much, much cheaper than you thought it was, which in many ways we had with the Medicare drug benefit. That turned out on some of this, not so much. I mean, there was more seniors turned out to be much more aggressive consumers than we had predicted. But that sort of thing. So income is, if it's not your first priority, boy, it's a close second on these ones. Conclusions. It was quite clear from the start that this might take a very long time. We were part of it. We were going to outside academics, and you know when you go to academics, don't hold your breath. It's going to be a year or 2 or whatever before they get back to you. It takes them a while. But it was also clear, and so this notion that much of this stuff has taken a decade to come, I don't think any of us who started at that point are wildly surprised by some of those things. But as I said, as I sat there in the Roosevelt room, I was sure my colleagues from the Clinton administration, my counterparts, had probably faced that, and I know that not much had been done in between, and so it was time to get started, at least to get started. And on this question about kind of, there's always this notion, especially if you're not that familiar with the policy and political world, to be a little concerned about kind of political heat you might get. And candidly, in a Republican administration, we were already being accused that, is this sort of an attempt to define away a problem and sort of say, you know, if you came away with it? So we were sensitive to that. But if you do see that there's a more accurate, a more rigorous way to measure these important questions, to get this data better, and you don't do it because of your concern about political heat, it is, I would say, professionally irresponsible, close to professional malpractice. If you sit there and you know the number's wrong, and you know you could get a better number, and you don't do anything, that's, you know, you get a little political heat, it'll go away in a week. But if if you sit there, we've got to improve this data. It's just too vital to the policy questions that are out there today. Thank you.
Good morning. I'm Gary Claxton with the Kaiser Family Foundation. I actually just have a few comments to make before there's time for questions and discussion. The first comment I want to make is I want to compliment the agencies for doing such a great job, for not only making the changes that needed to be made, for all the research that went into getting ready to make the changes, for all of their care, but also for, at least with respect to us, how open they've been. And we've been asking them questions about this for a number of months. We did a paper a little while back to describe when information would be available to look at changes in the ACA, and all the agencies were very helpful in helping us understand things, explaining things. So I think it's been a really transparent process and a really open and good process, and obviously the results look very promising. In particular, I want to say that the added focus in the ACA to transitions, so we don't think about coverage as a static thing, but as something that changes during the year, is really important and will help us understand things better. I mean, we had some of this with SIPP. SIPP's a wonderful survey. We use it a lot, but the CPS is bigger, and it provides state estimates, and that'll be an important addition. Another important addition, which I don't think has gotten as much discussion today, is the addition of questions about offers of employer coverage to the CPS. A number of important policy questions do revolve around whether or not someone has access to coverage. in particular whether or not you're tax credit eligible. And we'll also want to look more at both the offers of employer coverage and the wage and hour information from the CPS as we try to evaluate how the employer responsibility provisions change what's going on in employer practices, both for health insurance and for work. This is an important policy question. It starts next year, and this will be helpful information. As I'll say in a moment, I'm not sure it's everything you need to know, and SIP will be important there too, but it's a good addition. Since it's a technical meeting, I thought I'd do a couple of technical things. Mike was sort of big, and I'm going to think small for a minute. I think some challenges still that remain, and I don't know how much time I have. The first relates to the fact that the initial open enrollment period extended late into March and into April, and that the big surge was end of March and in April. And this was before, and this was after much of the data collection for the 2014 SIP and CPS, and also the first 3 months of the NHIS. In addition, for people who applied for coverage during that surge period, it probably wasn't effective until May, maybe later. I'm not sure we know how people who had applied for coverage but didn't have it yet would answer some of these questions. I think we believe from some of the Gallup results that people are reporting themselves as covered probably even before their coverage took effect, but we don't know that. So it's going to be a source of some ambiguity, and then probably one we'll never actually know the answer to. Or maybe a couple years in 2016 when we can look back 2 years in SIP, we'll maybe have some data, and I'll get back to that. So one of the important additions to the CPS is obviously being able to look back and track coverage to the prior year, and in particular, for 2013 to 2014, people really want to know, policymakers really want to know how people changed. What did they do? What kind of coverage did they used to have? Are the new people who got covered, previously uninsured? Did they move from one non-group policy? Did they drop employer-based insurance? And unfortunately, we're not going to know that right away, because many of the people we can tie back are the ones who were surveyed in January and February and the beginning of March. We're not going to be able to know how their ultimate 2014 coverage ties back to 2013 through the CPS. We will know that a year later when the SIP comes out, because we'll be able to tie back 2 years of coverage, but it's going to take a while. Obviously, we're going to learn a lot when the HIS information, the early release, comes out. From the private surveys that are out there, I think we already know a good deal about changes in overall levels of coverage. The private surveys are pretty consistent in having, changes that are of a magnitude of some percentage points that make us think it's 7, 8, 9 million people. They're all pretty different. Many of them are different in terms of where they start and where they end, but the changes are pretty consistent. But what they're not very good at is telling us about the coverage that people have. Matter of fact, some of them are not very good at that at all. In terms of public versus private and types of public and types of private. I know the early releases will only sort of separate it into public and private, but that still will be a nice addition to our understanding of what's going on. And the ability to look at states that expanded Medicaid and didn't as two separate groups will also be really helpful in that regard. Second point I want to make, and then I'll stop and let people ask questions, is that, which was pointed out earlier, and we take it from some of the surveys we've done. We do a fair number of surveys of people as well, is that people don't understand their coverage very well. And that particularly applies to some of the newly insured, because some of them have never been covered before, or they really haven't been covered by anything private before. Quite frankly, all this is really complicated for us. And for a person who can go to some place called a marketplace that's brand new, and when they come out of it, some of them have public coverage and some of them have private coverage, it's not really surprising that they don't know sort of what box they fit into very well. We also found that there are people who say that they have private coverage, that they don't have a subsidy or a premium tax credit. But if you look at their income and you look at their coverage history, like they've never had coverage before and they don't have any money, it's highly unlikely that that's true. And it's not surprising really, because you can go into a marketplace and they'll sort of tell you what you owe to enroll in something based on your income, and you may not understand all of the dynamics of that. So we're finding that people don't always understand that they're subsidized. I think the approach of asking them whether their premium was calculated based on their income is another approach that might work out, and I believe that's one of the things that's being done here. It also made me very happy to hear about all the editing that was happening and the collecting of information off insurance cards. The fact that so much of these surveys collect information in person and are able to look at documents and use insurance names is a good way to help correct for some of these errors. And asking whether or not people pay a premium is also an additional good piece of information. Just wanted to point out, make 2 points. One is the way the tax credits work, there are people who can enroll in bronze plans and not have any premium. So for them, we're still going to have some sorts of ambiguity because their tax credit is large enough that it covers the entire cost of their private premium. Also, some of the editing that's being done based on plan name makes a lot of sense, but I've spent a fair amount of time recently looking at rate filings from insurers, more than I ever wanted to again. And I will say a lot of insurers offer the same plan both on and off the exchange. And so using the name may or not be as helpful as we first think it will be. We'll have to wait and see. Final point I wanted to make was, as I said, adding the questions about to the CPS about whether or not someone who is working but does not have insurance from that employer, whether they were offered coverage, is a good addition. For the policy reasons I mentioned before, it's important to start to know that. But I do think we need to know more, which is whether or not the spouse was offered coverage, whether or not the children were offered coverage. Now, luckily, SIPP has that, or used to have that, and hopefully it still will. May not know it quite as quickly and can't tie it up to state estimates and do as much as you can with a CPS. That's an important question that we're going to need to know more about, and hopefully we can figure out ways working with these surveys together to inform that. But overall, I think this was really an exciting meeting, and I appreciate it. Thank you.
Hi, my name is Michael Cook from the Public Information Office at the U.S. Census Bureau. We're now going to begin our floor discussions and questions. Just some quick reminders, some housekeeping notes for people who are watching this via Ustream or listening on the phone. If you could please dial 1-800-857-4620 to ask a question. And remember that your passcode, participant passcode, is CENCHS. And we ask that you stay on the line until the operator asks for the passcode. Do not key in the passcode. Okay? So, also, another quick note, if you were looking for an electronic copy of the materials, if you navigate to the Census Bureau's website, on the homepage, you'll see a media advisory for today's event. On that advisory, you would click on it, and that would direct you directly to the electronic press kit. Inside the electronic press kit, you'll find all the materials from today's event, as well as an archived version of this video, this event. So without further ado, we'll go ahead and commence and begin with today's questions. And I'll take any questions from the floor first. And for those in attendance today, we do have a mic over to your right where you can ask your questions. I please ask that you use the mic so that the people listening via Ustream can hear you and be part of the conversation. And we have our first question. And also, I'd ask that you note your affiliation, if you could, please.
My name is Sarah Wheaton. I'm a healthcare reporter at Politico. And as far as the discussion about figuring out whether people have a public or a private plan, how are you characterizing, Mr. Blumberg, people who might be in the states that did alternative Medicaid expansions where they are getting premium assistance to buy health plans on the marketplace? And in some cases, those people do actually have a small premium payment.
Yeah, some of the more technical questions I may have trouble with, as I haven't been the one really getting my hands dirty in the data. However, when it comes to such plans in those states, even though some of that premium assistance may be coming from a public plan, if the plan itself is private and obtained through the marketplace, it'll be classified as private with our survey.
Thank you.
Hi, my name is Kitty Smith. I'm with the Council of Professional Associations on Federal Statistics. And the guy behind me may be the best one to answer my question, but for the sake of the...
This wasn't planned.
This wasn't planned. For the sake of the group, I'm aware that the Medical Expenditures Panel Survey conducted by ARC is a subsample of the National Health Interview Survey. And what I'm curious about is whether the questions asked of the panel, the MEPS panel, about health insurance coverage are the same as what are asked on the NHIS or different?
And I could answer that question. Steve Cohen from the Agency for Healthcare Research and Quality. There's been tremendous coordination in terms of trying to bring harmonization to the questions, particularly the enhancements to address the Affordable Care Act. But there is a bit more differences in terms of the venue of getting the data, in terms of we're first asking questions in our employment section, and it's a panel survey as well to get detailed information on all the household members. But there's been a number of research pieces that we've done over the years, NCH and ARC, looking at coverage estimates going from year 1 to year 2, HIS to MEPS, versus MEPS to MEPS, because MEPS is an overlapping panel design, and generally the trends are incredibly resonant, but they're not explicitly the same questions. So in many ways, that's why you saw what Mike O'Grady put up in terms of a modest differential between the two surveys, as well as there was a time differential. So hopefully that answered that question, but to get to my question now, Gary Claxton pointed out the surge that came about towards the end of March and early April, and the CPS will coordinate with NCHS on the March estimates. HIS is very rich in sample as well, and in the first quarter, you do many sociodemographic breakdowns. So it might be quite informative if you did a monthly estimate for March. I know you're going to have all the estimates in another 3 months for, you know, the half a year period, but that would be incredibly helpful. Is that something you're planning?
You talking about a monthly health insurance coverage estimate, or simply a monthly exchange-based coverage estimate?
Well, both. If you could put out, if you could put both out, you could actually combine, you know, January and February and then do March. I think it would be quite informative. You probably get questions on that front.
I'm fairly certain that a monthly estimate of exchange-based coverage at this point would not be stable, given the sample sizes available. As for a monthly estimate of health insurance coverage, that may be possible. It's not part of our current release plans, but, you know, remembering that we do release the microdata file from which we produce the quarterly estimate, it would be possible for somebody to produce a monthly estimate.
I kind of agree with Stephen. I think it's probably not going to be stable enough to really say anything about. We certainly can look at it, and if it turns out it's worth putting out, that's where we could put those estimates out on the website under that special tabulation. But the sample size is large, but not that large, and when you break it down to the month, which is why we've never put out month before, it's pretty small. We can take a look at it. What we do going forward, I think, is pretty much open.
Well, that's very helpful. If I could just make one more addition to the comments that Gary made in terms of information coming on the changes that people have given what their coverage status was in 2013 and 2014. While MEPS won't be there in September, by the winter, we will have estimates from the first half of 2013 for the panel going into 2014. So we could see what those transitions are. And I know Rand put out a report a couple of months ago, but we'll be having national estimates on that front. So thank you.
And one quick reminder before we have another question from the floor. For those callers that are on the line, if you could please press 1. Please press 1 if you are desirous of asking a question. And our next question from the floor.
Hi, thanks. I'm Bill O'Hare with the Annie Casey Foundation. And first of all, let me congratulate all the presenters on a very informative and engaging presentation. And my question is probably to Jennifer, but anybody else who wants to jump in. I think you did a good job of explaining how the new CPS healthcare questions are different than the old ones, and that will result in slightly different numbers and rates. My question is about whether you have any evidence or any reason to believe that that relationship between old and new questions will vary by geographic areas. I'm particularly interested in people inside and outside metropolitan areas, urban, rural, or states. I guess another way of kind of asking it is, the differential we've seen in the past likely to be true in the future?
Well, it's very hard to tell at this point. As I mentioned, that as Tori mentioned in our report, this fall we are going to concentrate just on the nation with the new CPS estimates, and we'll use ACS to look at the state and lower geographies. So these changes that we did to the CPS questionnaire, we really wouldn't be able to see in effect the year-to-year changes until next year.
Okay, Ken Feingold from ASPE. I have a question for Jennifer Day, and this goes back to, I think it's slide 21, which is the results of the CPS content test. And in a way, this kind of is the culmination of Mike's 10 years, Michael Grady's 10 years of work, is this result with the new improved test. I just want to make sure I was understanding the signs right on that slide. So on the left side, that with the wording that was tested, the uninsured rate is down 1.4 percentage points than what it was in production, the production version at that time. And is that for the full population?
That is correct.
Across age? And that is the previous year question, as it had been asked all along, right? Okay. So then if you go below that, you have the bars for changes in private coverage and public coverage, or government coverage, it's called here. And the government coverage is down 2.4 points. So does that mean that with the new question that was tested, that fewer people report government coverage?
That is in this comparison here,
Okay.
and as you remember, this is a comparison of a test to the production.
Right.
And that's what we were seeing in this particular comparison between these two different surveys. This was a sample size of about 16,000 people in the health insurance part of this questionnaire. It gave us enough confidence that we could see that these numbers were going in the direction that we would expect. But I don't know if this is going to indicate exactly what we're going to see in the future with the current population survey.
Okay, but I mean, I think the direction is still surprising for that, because it would seem that given that there was a Medicaid undercount, which the SNAC
Exactly.
research demonstrated, that you would have expected that the change in questions might pick up Medicaid better, in which case, then that would have gone the other direction then. So. Okay, but this is what the contest showed anyway.
It does
Okay.
seem a little counterintuitive.
Okay, and then the last part on that slide is that the private coverage, I think private coverage was picked up more, that more people reported private coverage in the new methodology.
Yes.
Okay, thanks.
Again, a quick reminder for those people that are on the phones, if you want to ask a question, please press *1. *1 for questions on the phone. Any other questions in the room? Operator, do we have any questions on the phone?
Yes, we do have a question from Joanna Turner from FHA DA.
Hi,
Joanna stated. Thank you. 2 questions. Will CPS state level point in time estimates be available along with the CHS? And will point in time be available on public use file?
I can answer that. This is Jennifer Day. Okay, so I got parts and pieces. She was asking, are we releasing, I believe, the current coverage status in the CPS on the 16th, which Tori covered, that we would be releasing some preliminary estimates along with NCHS when they put out their release on the 16th. And would it be available on the public use file? Our public use file variables will be exactly the same as what we had last year, so they will not be on the public use file.
Any other questions, Joanna?
No, thank you.
And operator, do we have any other questions on the phone?
No, there are no other questions on the phone queue.
Do we have any other questions in the room? Any comments in the room?
This is Charlie Rothwell. I'm going to say just a general comment. I think this is a good example of what federal statistical agencies are all about. Independence and cooperation. And I think this is a good example of it at its best. We have 13 federal statistical agencies throughout in various departments, in justice, in education, obviously BLS. We collect information that comes together many times to really paint a picture of the American people and our country in general. And I think health insurance is just one of those activities that obviously right now is at the forefront. But there are many others. And our job is to say it as it is and let other folks decide where the policy should be. So thank you all for coming, and I hope this was met your needs.
And with that, that concludes today's Federal Statistics on Health Insurance Coverage technical meeting on methods used in household surveys. Thank you, everyone.